everyone, and welcome back to the hashtag See Arthritis event. This is our 10th year in action with arthritis health professions from all walks of life and disciplines. We're so excited to be back this year. I'm Cheryl Cohen. I'm with Arthritis Consumer Experts and the host of this event. I am so excited. What happens when you get three powerful women on a screen? All heck breaks loose. So I'm super excited for this conversation. I'm joined today in this interview booth by Dr. Michelle Batthish, Dr. Karen Beattie, and Ms. Meghan Pancucci. Let me tell you, the audience, a little bit about each of them, and then we're going to dive right in. So Dr. Michelle Batthish is an Associate Professor of Pediatrics in the Faculty of Health Sciences at McMaster University, and her research interests are in juvenile arthritis care, treatments, and outcomes. Her bio is about 40 pages longer than that, but in the interest of time, as is Dr. Beattie's, I'm going to just cut to the chase there. Dr. Karen Beattie is an associate member in the Rehabilitation Science in the Faculty of Health Sciences at McMaster University, and her research interests are in autoimmunity, clinical science, patient and citizen engagement, and patient-centered care in rheumatology and rheumatoid arthritis. And Ms. Pancucci is a student at McMaster University and plays for the university's water polo team, a fellow athlete. Woo! I hope the season's going well if it's started already. I'm not so sure what the schedule is, but we'll get back to that. So welcome, powerful women. We're so happy to have you in the studio.
Thank you for having us.
Thank you. It's nice to be here.
Yay. So the reason we roped you three into the studio is to talk specifically about patient and family engagement in rheumatology research. So lay terms, how do you get families involved in the research that you're doing? Super important topic. But first, before we dive into that, and you tell us a bit about what you're going to be covering in the workshop, I'd like to start with you, Dr. Batthish. Why don't you just tell the audience a little bit about yourself and situate yourself in your clinical research and your clinical practice?
Thanks, Cheryl. So my interests in patient and family engagement and research stemmed about a year ago when I took a course along with Karen offered at McMaster on patient and family engagement and research in general. And it was a wonderful course where both researchers and patients worked together to learn more about what is patient engagement and how are patient partners different from participants in research, because it's clearly a very different role that they engage in. Historically, we think of patient participants as, we recruit patients into research, they complete surveys, they answer questions, they're maybe in an intervention, and we study and their results and outcomes. Patient partners play a very different role when it comes to engaging with researchers. And they can participate throughout the entire research life cycle, from the very beginning, where we are thinking of a research question and want to design a study. We may seek out patient input and feedback on that. Throughout the study, where we may be designing an intervention or a survey and seeking out their feedback about how to best do that, all the way to the end, where we are ready now to share our results with our stakeholders and how do we best do that. So we could definitely engage at multiple levels throughout the research life cycle.
Yeah, it's really cool. You're absolutely right. Like myself as a person in a study versus Cheryl Cohen, who's sitting with you at a table saying, what is the right question to be asking right now in this time, in this area of research? From my perspective, as the person living with the disease. So we call that lived experience or lived expertise. Amazing. I'm so glad that the both of you, Dr. Batthish and Dr. Beattie, have gone all in. It's like, when you're playing poker, you've pushed all your chips in the middle of the table. Dr. Beattie, tell us a little bit about your work and your view on the topic of patient engagement, especially as it relates to families. It's one thing to get a patient who is adult involved as what I call maybe an informant or a partner or a collaborator in research. versus a juvenile patient and their family, or just the parent or caregiver in the family versus the young person? What is that dynamic?
It's a really powerful dynamic, to be completely honest. And I think it's very empowering for patients and families. So my role in the Department of Pediatrics at McMaster, professionally speaking, is that I lead patient and family engagement in research. So it is my job and my responsibility to partner people with lived experience with researchers while a research project is being developed, while ideas are being generated, while protocols are being developed. Like Michelle said, at different stages of research, there's different ways that patients and families can partner. And I think it's really important to recognize the value that patients and their families bring to every single stage of the research process. And I think it's really our responsibility as researchers and clinicians to be able to share with patients and families how needed and how valued they are. You know, there's that saying, nothing about us without us. And I think there's recognition of the value that patients and families bring from granting agencies, from journals, where patients and families, it's no longer just a nice thing to have a patient partner on your grant or maybe on a paper that you write. It's absolutely necessary. We cannot do this. We cannot have impactful research without partnering with patients and families. Yeah. When it comes to youth, they play a vital role. I can't tell you how many conversations I've had with researchers about research projects that get, you know, that swing 180 degrees after they've talked to a patient or a young adult who has been there, done that in their journey with a condition. And all of a sudden they're thinking about things in a completely different way, or they're reprioritizing what they initially thought was of value or was important, because all of a sudden they've talked to a teenager who tells them something different that they didn't know. Without partnering with patients and families, you just don't know what you don't know. Right. And that's what they bring to the table. So right. I think it's, you know, there's certainly probably an age where we know that that youth and young adults would feel more comfortable speaking without a parent, but that's also really necessary. Until they get to that stage, partnering with parents is really what we focus on.
Yeah. And, you know, I mean, parents bear a huge responsibility, don't they, in terms of their own advocacy, in terms of expressing or trying to express best they can thoughts and feelings and experiences of their child. Because even in that process, it's a translational exercise. And I would suspect nearly all of the time they get it right because of that tight bond, that beautiful bond of parent and child. But until that child gets to a certain age, you never really know, right? You never really know if that's their lived experience. And then as they get older, you know, you start to see sort of the full flowering of that experience. Meghan, okay, I don't mean this as an insult to the others of us on the screen, but Meghan, you're the closest end to the youth spectrum here. And so I'm curious to know, when you think of this engagement in juvenile arthritis and parent, how do you view it? How is it maybe different? You're not far out from being someone who might have transitioned from adult care to you know, or from juvenile care to adult care. What do you see from your perspective as a young person in research?
For sure. So I actually was a patient in Dr. Battish's clinic. I was diagnosed with JIA when I was 11. So I was a patient and a participant without really understanding at that age what that meant. And then I got older and reached out and wanted to work with her. And I thought this was a perfect place for someone like me to be, because I have like a little bit of the research knowledge as an undergrad student, but then a lot of the knowledge as a patient. So because I'm able to look over questionnaires and think of how I would have perceived that as a 13-year-old or a transitioning patient, it puts it into perspective on how important I am in this conversation. So yeah.
That's incredible. Thank you for disclosing your own personal experience. And it's not uncommon that we have, and I'm sure Dr. Batthish and Dr. Beattie have seen this many times too, where people coming out of a juvenile arthritis experience and who are interested in going into the healthcare field go into the very disease that is affecting them. It's almost like pay it backwards, pay it forwards at the same time. So congratulations on where you're at right now in your journey as a researcher in training. I'm going to ask you a completely tangential question at the moment, so just hold tight, doctors. Meghan, when you play sport, so many kids, when they're getting diagnosed and their parents think that's it, I'm not going to be able to do any of the things that I want to do in my life, but here you are, you're on your university's water polo team. Tell us what that's like. Do your teammates know what you live with?
They do. So I definitely felt that when I was first diagnosed. I couldn't walk, so how can I skate again? How can I run? How can I swim? But then after I was on medication for a little while, it was just kind of a conversation with coaches and teammates that if I'm sitting out, it's not because I'm lazy. I have other things going on. So I think after that conversation is had, it's very empowering to be able to be someone with a disability and can still compete in sport.
Yeah, and that comment, I mean, my heart, I've got tingle goosebumps on the back of my neck. I had a similar experience to you, but with rheumatoid arthritis that was adult onset. And describing how you go from a high performance athlete to not walking is not easy, and then back again. So thank you for sharing that and for doing your advocacy work at a real personal level and now a professional level. Doctors, when you listen to what Meghan was saying about the perspective, about her own expertise and now bringing it into the research lab, you know, the theme of this meeting in Winnipeg is shared decision making. What are some of the successes you've seen over the last decade in shared decision making between, you know, juvenile, patient, parent, and you? What do you see as advances, and what continues to challenge you in clinic when it comes to shared decision making?
I think the fact that the theme is already shared decision making is a huge advance.
Yeah.
You know, 5-10 years ago, that was not in our regular day-to-day language. And I think we're all at the point where it's just become a natural thing that we incorporate in our clinical lives. And I think patients and their families have come to expect it as well. They've become quite informed about their illness and the medication options that are available to them. And so I think it's become an expectation to incorporate kind of in just day-to-day life in clinic. And then I think, you know, extrapolating that to the research world, I think, you know, that's what patient engagement is like as well, where, you know, on the clinical side, you have patient, family, and the clinician as equal partners deciding on a treatment course, for example. When we engage patients and their families in research, they're an equal participant at the table when it comes to any decisions around a research project. And so we've come to depend on partners just like Meghan to give us her feedback and her advice and her own experiences to make our project better so that it's successful and meaningful.
It also creates...
Can I share something there, Cheryl?
Yes, go for it.
I was just going to say, you know, this the idea of shared decision making in research is really important, and sometimes what a clinician or a researcher might prioritize might actually not be on the top priority list of our patient or a family. And Michelle and I were lucky enough to kind of have a holiday dinner just before Christmas time in December, and we were sitting at a table with Meghan and some of her peers, and you know, we just flat out had a discussion about you know, what's important to you when you're preparing to transfer to adult care. What are you worried about? What do you want to know about? And a lot of Michelle's focus in research is on the transition process. Meghan has transitioned to adult care, and so she has lived experience there. And she said, she was able to tell us, what's important, what was hard, not just her, but the others as well that were at the table, who also have lived experience. And, it helps to inform what how Michelle and I are going to write the next grant, or what we're going to focus on. And so we really rely on them to say, this was hard, and we think we don't really know much about it. So Michelle and I need to do some research about it. So really not even just being actively engaged in a project that's already on the go, but really informing us about where our priorities should be, and they should really be the ones driving what the research topics are.
Yeah, that's incredible. I'm going to use a pun very intentionally here about you having set the table for that discussion quite nicely at the holiday time. One, it's a time during the winter solstice when just inside of ourselves as humans, we're probably in a bigger giving or sharing sort of space, headspace. One of the things that's been a problem in shared decision making has been equity. And this is particularly true in patient engagement. I regret to say I'm old enough to have been around when, the first patient engagement model was created in the Canadian Arthritis Network. And I would often find myself at a table with 30 world leading researchers and myself. So 30 voices of expertise and only one of expertise through my lens, through my experience. And so there was great inequity, not just in terms of the voice and what I was saying and the points I was raising, but just sheer numbers. My availability, the availability for me to speak at that table was 1/30th of the availability of all the experts. So I listened and heard carefully when you said it wasn't just Meghan at that dinner table, it was a number of people. And that is so important, I think, in what you are trying to do in your work. And that is to create equity in decision making around research, what research takes place and when and how. Meghan, when you think about sitting at those tables, what elements help you be your best participant, best collaborator, best co-investigator, whatever level it is that you're getting involved at? What needs to be there for you?
I think it is really important to have those other kids there. Just if I don't know how to kind of say what I'm thinking in a way that Michelle and Karen would understand, I'm able to talk to them and say, well, what do you think? And how would you say that? So I think it is important. And I've only ever experienced this kind of research lab, which we like so many of us are like youth that had diseases like the ones that we're studying. So I think that space, just them being there and knowing that they're kind of depending on all of us, makes me feel better about the research that's being done.
So it's your own level of collegiality at that table that helps power you, helps you literally physically open your mouth and say what it is that's on your mind. And doctors Beattie and Batthish, I want to sort of highlight for those in our audience who are researchers and tuning in, or clinicians and tuning in, what Meghan says here is a really important piece. And what she's just talked about is modeling in our world what happens in your world. When you have a number of your peers at the table, you also lean over and say, hey, what about this? Before perhaps you're even comfortable saying, okay, we've got an idea coming from, the rehab world here. We've got a comment here coming. That opportunity needs to exist as well for people who have the lived experience at the table. And I think I hear a lot from researchers. They don't necessarily say it to me directly, but they say, well, we've got one person there. We've ticked that box. And what I hear you guys saying is something fundamentally different. This is not window dressing. This is how do we create that same level of collegiality, that same level of empowerment for people who have lived disease in our research. Is that a correct
Absolutely.
takeaway?
I think it's, yeah, we have to move away from just ticking a box and saying,
Yeah.
you know, yep, I have my token patient partner, I can move on. I think it's essential that you have a representative group of partners that represent your actual clinical patient load, so that their voices are representative of what you are seeing day to day. I also think it's essential that you create a safe environment and remove some of that hierarchy, because, you know, I could imagine it could be intimidating for a youth to attend a meeting with their ex-rheumatologist, you know, and so you need to be able to create that safe, engaged environment where they are able to just speak out and voice whatever opinion they may have on a particular topic. And then as the researcher, you need to be open to whatever is coming at you as well.
Yeah. Dr. Beattie, anything to add to that?
Yeah, I kind of sit on two different sides of the fence when it comes to my job and kind of life in general. I also have lived experience as a mom of a child who was born a micro premature infant, and I have served on many different groups as the parent partner, who is informing researchers who are like me. And so having been able to have that experience of being the researcher and being the partner really empowers me to be able to say, I know that this is what I appreciated when I partnered with a researcher, and I'm going to make sure that every youth, every child, every parent that sits around the table with me is going to feel just like that. And the point that Michelle made with respect to psychological safety is absolutely imperative. That if you are going to partner with a youth, or you are going to partner with a parent or someone else with lived experience, if the culture of your table or your Zoom meeting is not psychologically safe, what you're getting out of your partner is pure tokenism.
Yeah.
It's checking a box, and that's not okay. We've done that a lot in the past, and there's no room for tokenism anymore. We're kind of over that, been there, done that. And I think we're able to see that now when we're reviewing grants that have a partner on them. We're really looking at what is the role of the partner? What is the involvement of the partner? You know, if you just put their name down, but they're not mentioned anywhere in the grant, it's like, yeah, I don't really think that this is true, meaningful, genuine engagement. And that's a problem. And so I think there are reasons why researchers do that. I think sometimes researchers don't feel necessarily comfortable or confident in being able to partner, and that's okay. There's tools, there's education, there's training that's available to support researchers in knowing how to partner, or how to partner in a meaningful way. It's not like you don't get this training necessarily when you do a PhD like I did, or when you did an MD. But there is other training available. And so some of the barriers that researchers face in being able to partner, one of them is really, I don't know how to do it, or I'm not confident in doing it. And you know, there are resources available. And on the flip side, you know, it's really, really important that the getting the most out of your partners, your patient partners, your youth, whatever, is really, a lot of that is dependent upon the environment that you set up.
Yeah, I hear you loud and clear, and really excellent points made by both of you. And I guess just to tie a bow on that is understanding and respecting what the person with the lived experience wants to get out of it, right? It used to be, what do I as the researcher get out of this, right? And it cannot be that anymore. And to your point about safety and space, whether it be virtual or in person, we also now need to consider cultural appropriateness in discussion for our Indigenous partners and patients, the significant differences that come into a room when you have people who are patients who are Indigenous and have such different experience than settler colonial patients. So all kinds of room for learning, and learning is a good thing. And I think that's what I'm hearing from the three of you. Every day you come to your table, your work table, your dinner table, and you're talking to each other in a meaningful way, and you're learning and then planning, learning, relearning, planning, and then doing.
And then writing, you forgot that
And then
part. You gotta write
doing,
it up. You
yeah,
gotta write it up.
and then doing, yeah. You've all been so generous with your expertise and time and views. I want to give the last word to Megan, with your permission. Meghan, if you have some couple of pearls to share with someone who's younger than you now, going through a juvenile rheumatology experience, what would you say to them about today and about the future?
That those questionnaires and surveys that you fill out are important, and you taking the time to understand what's being asked and giving your actual opinions and feelings on those are important, because there's lots of talk about transition, but once you transition, you still have this disease. If you are diagnosed with any of these diseases, it will be with you for the rest of your life. So helping your doctors help you is important now and for the rest of your life.
That's beautiful. A quote from the Jerry Maguire movie. How could we want anything more? Help me help you. And you know, that observation, Meghan, is so, in my view anyway, spot on. Not that you need me to validate it, but we get asked to fill stuff out, it seems, every day as patients without any knowing about why we're doing it. And if we understood the why, I think we would be more engaged as patients, right? Which an engaged or a highly engaged patient usually ends with better outcomes. So thank you so much for that. Doctors Batthish and Beattie, always a pleasure and an honor to sit with you in studio, virtual or in person. Meghan, I really appreciate your disclosure, your openness about your own experience and your own aspirations as a health researcher. Congratulations on everything you've done so far in life. And I'm a fan and I'm in your corner. Thanks
Thanks
to
for having us.
Thank you,
the three
Cheryl.
of you. Have a good afternoon. And to our audience, thank you for tuning in. We'll see you again for the next #CArthritis interview. Bye for now.